सुनिरहेछ?
Good afternoon, sir. सुनिरहेछ सर.
के छ साथीहरु आइसक्यो सबैजना अब के गर्ने सुरु गर्ने?
सर 2 मिनेट गरौँ न है. सर सबैजना आइसक्यो.
मेजोरिटी मोस्ट अफ द पार्टिसिपेन्टहरु आइसकेपछि मलाई एकपटक जस्ट इन्फर्म गरा है सर सुरु गरौँ भनेर.
हस् सर. सर सुरु गर्दिदा हुन्छ.
गुड आफ्टरनुन एभ्रीवन. यो धेरै पछि आफ्टर लङ ग्याप फेरि रेडियोलोजीको सुरु भयो. आज चाहिँ टुडे वी आर गोइङ टु डिस्कस अबाउट सम अफ द रिसेन्ट एडभान्सेस इन द रेडियोलोजी. एकदमै एडभान्स नभए पनि अहिले यो ट्रेन्डिङ उसमा छ हैन हाम्रो कन्ट्रीमा या अरु कुनै फरेन कन्ट्रीजमा. अनि जुन कुराको बारेमा अलिकति आफूलाई पनि आइडिया हुनुपर्छ हैन. लाइक दिस सर्ट अफ इमेजिङ मोडालिटिज आर एभाइलेबल. यदि कुनै यस्तो चीज छ हैन भने हैन कुनै आफ्नै रिलेटिभ्सलाई या कसैलाई यदि कुनै एउटा डिजिज भयो या यु वान्ट टु टेस्ट समथिङ, दिस सर्ट अफ मोडालिटिज आर अल्सो देयर हैन व्हिच क्यान हेल्प फर फर्दर डायग्नोसिस भनेर चाहिँ थाहा हुनु चाहिँ एकदम इट इज क्वाइट बेटर. अब अहिले के छ रेडियोलोजीको त अब जताततै एकदम एभ्री डे देयर आर लेटेस्ट एडभान्समेन्ट्स हैन. सबै कुरो भइरहेछ एभ्री डे हैन. नयाँ नयाँ एडभान्समेन्ट भइरहेछ. एटलिस्ट यु शुड बी अल्सो युज टु लाइक अल दिस थिङ्स. के पठाउने जस्तै मेटास्टेसिस भयो एउटा कुनै लङ्समा या कुनै एउटा पार्टमा क्यान्सर छ या सिए छ भने यसको स्प्रेड कहाँ छ भनेर पत्ता लगाउनलाई कुन इमेजिङ मोडालिटिज आर देयर. लेटेस्ट मोडालिटिजहरु के छ which can help you like for further like diagnosis or like helps in the improvement of the management. Right? We will discuss about various imaging modalities. अब हेरौं ultrasound ma generally like nowadays like even we in Dhulkhel also we have got this machine. We have got 3D and 4D ultrasound. पहिलाको जुन अल्ट्रासाउन्ड हुन्थ्यो जुन हामीले युज गर्ने अल्ट्रासाउन्ड मेसिन, it used to be only 2D ultrasound machine with color Doppler. Now you can see here, like you can see the face of the fetus. You can see the limbs of the fetus. If any defects are there, like if like one of the finger is absent, if there is club foot, or if any major like facial abnormalities are there, you can easily detect. This is called volume rendering imaging. Like it will create from the source image, it will create a 3-dimensional image, and you can see like you can see the tongue is coming out. You can see the tongue of the fetus. You can see the
सर स्लाइड शेयर नै भएको छैन त छैन सर.
एकछिन है स्लाइड शेयरमा जाँदाखेरि कसरी जाने त्यो अप्सन?
सर तल शेयर स्क्रिन भन्ने हुन्छ ग्रीन कलरको हेर्नुस् सर.
कहाँनिर छ भन्दा मलाई ठ्याक्क त्यो उसमा
सर जुमको ठ्याक्क त्यो उसमै एपमै तल हजुरको स्क्रिनभन्दा तल सबसे च्याटको साइडमा सेयर स्क्रिन भन्ने ग्रिन कलरको एरो जस्तो छ त्यहाँ क्लिक
एक
गर्नु।
मिनट एक मिनट एकछिन है जस्ट ए ल ल ल अहिले भेट्यो यस्तो लाग्यो एकछिन invite record in this community participants देखिन है अझै एकछिन ए ल भेट्यो अहिले आयो
आयो सर आयो।
है त ल अब सुरु गरौँ है त यो 3D अल्ट्रासाउन्ड मेसिन है नाउ अहिलेको एडभान्समेन्ट भनेको पहिला पहिला जस्तै कुनै एउटा इमेजिङमा कुनै प्रब्लम भयो हैन हैन कुनै एउटा प्रब्लम आयो भने हैन लाइक इफ देयर आर सम डाउट्स हैन स्टिल देयर इज टु बी सम डाउट हैन अब कहिले कहिले कति कुराहरू फेसहरू यसरी देखिँदैन nowadays you can see like this sort of three-dimensional images which are almost like a real fetus देख्यो हैन तिमीहरुले अहिले अहिले त क्लियर छ
यस सर।
है अब हेर हैन जस्तै you can see the whole face you can see the limbs and you can see the hands foot so if any major defects are there if the patient is having rhizomelia if somebody has 5 digits 6 digits or 4 digits if the child has got club foots you can see on this 3-dimensional or 4-dimensional ultrasound similarly you can see here this is a normal fetus and you can see here there is a cord around the neck you can see there is a umbilical cord around the neck and this is a normal like 2-dimensional ultrasound we have got some suspect whether there could be some defect on the lip on a normal ultrasound so with this 3D and 4D ultrasound you can see here there is a defect this is a case of cleft lip right so now you are quite clear so that you can plan like the child might be born with like some defect in the like face so you can plan accordingly like after the birth of the child also like you can like plan for the like surgery immediate surgery when it is required even for the feeding of the child because sucking is quite difficult in this type of child so like you can plan and you can do all this you can do the post delivery like preparation also accordingly and if you see like measure like measure anomalies over there like meningomyelocele so like some other gross congenital anomaly you can terminate like before 20 weeks of the gestational age now these are the like like advancement in ultrasound and there are some other advancement also there are elastography there is like even contrast ultrasound, which we don't perform quite often in our country because like contrast ultrasound is quite expensive, and on the same price you can do the CT scan. So still it is not yet common in Nepal, and it is not FDA, not approved by FDA America. So in few European countries they do contrast ultrasound, which are quite sensitive. Now coming to the imaging in the stroke, like what are the recent advancement in the imaging of the stroke and what you should know. होइन एउटा हाम्रो जस्तो सेन्टरमा या कुनै पनि ठाउँमा कोही मान्छे स्ट्रोक लिएर आयो होइन, लाइक वान साइडेड विकनेस लिएर आयो भने फर्स्ट थिङ यु हेभ टु डिफ्रेन्सिएट वेदर इट इज अ हेमोरेजिक अर ischemic infarct. Once you rule out that there is no hemorrhage, but still you have to make sure whether there is an infarct or not, whether it is just a TIA, whether it is an infarct, whether you should go for some acute intervention, or you can just do symptomatic management. So what are the things you can see here? These are the CT scan images. This was taken on 2 hours and this was taken on 2 hours. The patient presented with weakness of the left side of the body. So on 2 hours CT scan, you can see here at this level, everything looks normal. Again, here in the slightly upper section also, everything looks normal. Once you did CT scan again after 24 hours, now you can see there is an infarct on the temporoparietal lobe. There is an infarct. So in between 24 hours, 22 hours, there is a major change in the CT scan. So if this diagnosis would have been made slightly earlier on 2 hours, you could have done intra-arterial thrombolysis. So you can do like intervention radiologists around the world, even in Nepal also. What they do is like coronary angiogram, they put the catheter, they take the catheter to the brain, like to the concerned vessel. Most likely this is a middle cerebral artery, and they do the suction of the thrombus or they do the lysis of the thrombus. So, the changes which appeared after 24 hours wouldn't have appeared. So what we can do to detect the infarct quite early? के गर्न सकिन्छ त? We can do MRI, but even all the MRI are not that significant. And even MRI ma pani changes to detect the early changes, it might even take 6 hours or even 12 hours or more. त्यस्तो बेलामा के गर्न सकिन्छ त? Now we have got new imaging sequence in MRI, which is called diffusion weighted MRI. Now you can see CT scan of the patient was normal, but we did diffusion weighted MRI. Diffusion ma दुईटा component हुन्छ. एउटाको नाम diffusion, pure diffusion weighted MRI. The अर्को चाहिँ ADC. ADC means apparent diffusion coefficient. अब यहाँ हेर त के भयो? You can see the bright you can see on the temporal lobe involving the basal ganglia. It is quite bright on diffusion weighted MRI, and on ADC it is black. यो के हुनुपर्छ त भन्दा कहिले पनि एउटा डिफ्युजन मात्रै गर्ने होइन. Together with diffusion, you have to do ADC also. Diffusion ma bright देख्यो, ADC ma dark देख्यो भने it is hyperacute stroke. Even within 7 minutes of the clinical onset of the symptoms, if you do MRI, diffusion weighted MRI, it will detect it. It takes not more than 2.5 minutes to complete this sequence. So if you have got clinical suspicion of the infarct, and if you do CT scan, which is normal and which rule out hemorrhage, you can, if you are sure that there should be something else, like the patient is having severe weakness, so there should be something. So it is a 2-minute sequence which shows there is an infarct. त्यो भयो भने के गर्न सकिन्छ त? Immediately you can do the intervene and you can save the brain. And even some of the changes are reversible. है त्यो hyperacute stroke छ भने. So तिमीहरुलाई पनि के थाहा हुनु पर्यो, even अब पछि गएर अब you are about to complete your MBBS, सकिएपछि पनि हैन यो त CT scan गरेको normal छ भनेर आरामले normal भनेर you can't relax. Again, if you do MRI, if you are damn confident that there should be something else, you do MRI with diffusion. Like you should tell the technician, please do the diffusion weighted MRI. So what will happen? You will see this type of changes which were not seen in the CT scan or even in many other normal MRI. Again, here you see the patient presents with dizziness, severe vertigo, or like vomiting. CT scan was normal. And CT scan for the posterior fossa is not that useful because there are artifacts from the bones which will give some false positive or sometimes false negative imaging. So MRI is always useful. So again, on the diffusion weighted MRI, you can see here on the medulla and on the cerebellum, you can see there is hyperintensity. On MRI, you use the term hyperintensity, which shows there is a acute infarct or hyperacute infarct. Now, again, you can see there is a CT scan is normal. On MRI, this is a normal diffusion weighted MRI, and this is the ADC on the basal ganglia and along the region of the posterior limb of the internal capsule. You can see there is hyperintensity and there is reduced signal intensity on ADC, which shows there is a lacunar infarct on the basal ganglia and the internal capsule. And these are quite vital areas, internal capsule, basal ganglia. Although the infarct is small, but the impact is more. अहिलेसम्म सबैले बुझिरहेछ? Is it
Yes,
clear?
sir.
होइन? So यो चिज चाहिँ quite like you should know this है. यो चाहिँ recent advance भने पनि now our even Dhulikhel Hospital and some of the like other bigger centers in Kathmandu, we have got this facility. So at least you should know now, like MRI मा diffusion weighted MRI भन्ने छ जसले चाहिँ एकदम इन्फाक्टमा सिटी स्क्यान इज नर्मल अप टु 24 hours इट कुड बी नर्मल. अनि त्यो भनेर चुप लाग्नु भएन. इट विल लाइक डेफिनेटली मेक अ बिग इम्प्याक्ट अन द म्यानेजमेन्ट एन्ड यु क्यान सेभ द पेसेन्ट है. सो यु सुड नो अबाउट दिस रिसेन्ट एडभान्स. Again, same thing here, you see, this is the diffusion weighted MRI, this is ADC, this is T1. Again, on T1, it looks normal. T2, it looks normal. Flare, it looks normal. But here on diffusion, again, there is changes. So this is hyperacute infarct. And we have done MR angiogram. Without giving contrast, you can see the vessels. What is the condition of the vessels? Here, what you can see, this is the right middle cerebral artery. On the left middle cerebral artery, there is occlusion. So there is a occlusion on the middle cerebral artery, which is causing hyperacute infarcts. And if you can, like do the thrombolysis, most of the part of the brain could be saved. The patient can recover. ठिक छ है. ब्रेनमा स्ट्रोकमा कुनै कन्फ्युजन छ तिमीहरूलाई?
No, sir.
छैन है. अब हेर, कोरोनरी एन्जियोग्राम. कोरोनरी एन्जियोग्राम कसले गर्छ हैन? तिमीहरूको पनि रिलेटिभ्सहरू कसैको फ्यामिली मेम्बर्सहरूको पनि कोरोनरी एन्जियोग्राम गर्यो भने सुनेको पनि होला. What is coronary angiogram? You put a catheter either femorally or through the radial artery. You just go to the heart, cardiac major vessels, right coronary artery, left coronary artery. You just give the contrast and you see the like coronary vessels, whether there is any like stenosis, whether there is any occlusion, like the patient is having chest pain, like if there is a severe chest pain, you have to take to the cath lab. You can do the CT angiogram. Conventional angiogram. Here, the red arrow shows there's a significant stenosis on the right coronary artery. Again, on the next, like after the dilatation by the balloon, you can see it has been dilated. So all the patients with chest pain doesn't need coronary angiogram. Sometimes the patient might have a risk factor, like some angina type of features. So what we can do, coronary angiogram is an invasive procedure, like you have to do the puncture of the femoral artery. Sometimes there could be complications. So there are some minimal invasive or almost semi-invasive like techniques. On daycare basis, you can do the angiogram, CT angiogram, and immediately you can go to the heart, go to your home. So this is coronary CT angiogram, and you can obtain this type of 3D images. You can see this is the left coronary artery. This is the left anterior descending artery. This is the left circumflex, like coronary artery. And here you can see this is the right coronary artery. So there are various branches which you can see on a 3-dimensional images without giving, like puncture to the femoral artery. Like a normal CT abdomen, like the technique is almost like doing normal CT angiogram, normal CT abdomen, and you can obtain this sort of images, which are quite good for the patient with angina, or maybe some of them they might present with chest pain, musculoskeletal pain, but he has got some familial history, some other risk factor are there. At least instead of directly going to the conventional or catheter angiogram, you can do the CT angiogram, which is non-invasive. Immediately you can go home. Now you can see this is the BRT three-dimensional image. This is again, like what you can see. This is a CT angiogram, and this is conventional angiogram. Here on the left circumflex artery LCX, you can see there are calcified plaques, which is causing significant narrowing of the like left circumflex coronary artery. And again, you can see on the conventional angiogram there are stenosis, and on the left side you can see left anterior descending artery. You can see it is normal. So this is a CT coronary angiogram. So again, if you have got familial history of like ischemic heart disease, like you are hypertensive, you have got like hypertriglyceridemia. So if various other features are there, you can do CT coronary angiogram, and you can find out the like all like what are the causes of the chest pain. Similarly, you can see the angiogram. There is a big arteriovenous malformation on the thigh. This was the patient. This CT angiogram was done in our hospital. The patient presented with large swelling of the thigh, and we did the CT angiogram. You can see there is a big arteriovenous malformation. This is the like superficial femoral artery, and there is superficial femoral vein. There was a big like malformation, arteriovenous malformation was there due to some trauma, long-standing trauma, because of which there is like the artery has got quite high resistance flow, vein has got slow flow. So there is communication which led to the like dilatation of the perforators and all the superficial veins, which led to the large pseudomass on the thigh. So this is also CT angiogram. Again, this was also done in our hospital. The patient, this was a young child, a young girl with swelling of the left side of the face, and we did CT angiogram, and we found like there was a arteriovenous malformation. You can see on the lateral side of the like face, there is a big like arteriovenous malformation. So these sort of facilities are available. So here what we can do the like we can put some like media which is called like sclerotherapy. We can do the sclerotherapy. We can do the like occlusion, percutaneous occlusion of this like the supplying vessels, and we can occlude all these vessels which are not necessary, right? अब अर्को हेरौँ होइन CT angiogram for renal. Sometimes one of the most common cause of hypertension like is renal artery stenosis. And one thing, okay, like before going for a donation like a renal graft, like you might have heard like people are going for renal transplantation. Before going renal transplantation, nowadays what we can do CT angiogram to plan for the like surgery. You can see on the right side it is normal, there is a single renal artery. On the left side there is one accessory renal artery, and this is the main renal artery. So if you want to like donate this left kidney, it is quite difficult, because there is again one small vessels which is supplying the left kidney. So you can't go for a renal donation, you can donate the kidney, right? So CT angiogram, on a normal CT angiogram, you can see there is like accessory renal artery, and there is focal stenosis at the origin of the left main renal artery. Again, same thing. This is called MIP, maximum intensity projection image. This was a case like here you can see there was a case of hematuria. You can see there is saccular aneurysm at the renal artery. Again, here you can see the patient presented with, this was a 42 years female, presented with hypertension. Here you can see, again, you can see there is stenosis on the accessory renal artery. So renal artery stenosis is one of the most common cause of hypertension. So again, you can see there is narrowing at the origin of the left accessory renal artery. एन्जियोग्राममा के कन्फ्युजन छ त तिमीले बुझ्यौ होइन
Yes, sir.
है सिटी स्क्यानबाट without doing any extra things in the modern CT scans, like CT scan, like in our hospital, without doing any extra effort, you can do the 3-dimensional, you can do the angiogram of each and every part of the body, each and every part of the organs, whether it might be hepatic artery, any vessels within the brain or within the abdomen, like we are talking about renal transplantation, you should know all the like renal arterial system. If you are going for liver transplantation, you should know the every segment of the hepatic artery, the hepatic veins and the portal veins. So now MRCP को फुल फर्म थाहा छ तिमीहरूलाई? Magnetic resonance cholangiopancreaticogram, होइन? पहिला पहिला के गरिन्थ्यो, like for diagnosis of any obstructive jaundice, people they used to do ERCP for diagnosis. Nowadays ERCP is limited only for therapeutic purpose, होइन? If there are some stenosis, if there are some calculus, only you do ERCP. Otherwise only for the diagnosis of obstructive jaundice you don't do ERCP. What we do MRCP. So which is available, again these sort of things are available in our hospital. So you should know the normal anatomy. You can see these are right and left hepatic duct, which combines and forms common hepatic duct. Again, cystic duct will come and join and it will form a common bile duct. And common bile duct normally opens into the second part of the duodenum, like you can see at the ampullar region, like major papilla. And again, you can see one small duct is there. This is a pancreatic duct, which is again opening together with the common bile duct at the second part of the duodenum at the major papilla. So there could be some anatomic variations. So before planning for any surgery or any procedure, you should know about the anatomic variant. See, this was a case in our hospital. The patient presented with like severe pain abdomen, on and off pain abdomen. The patient used to have pancreatitis. So like many other investigations were done, which are all normal. So what we did ERCP, MRCP. What we found, CBD is opening at major papilla, but the main pancreatic duct should have opened in the major papilla. Instead, it is going towards the minor papilla. So this was a case of pancreatic divisum. And one of the common cause of severe pain abdomen, acute pancreatitis, recurrent pancreatitis is pancreatic divisum. So how we can see the, how can we can diagnose the pancreatic divisum? Through MRCP, not even through ERCP. So you should know, like there are some imaging modalities which helps us, like this is quite common in our country. Patient is having severe pain abdomen, all imaging, all investigations are done, everything is normal, you can't find the diagnosis. But if you do the MRCP, definitely you can see this is the cause of his pain. Again, can you like this is the MRCP image. Can any one of you, like tell me what could be the diagnosis? के छ यसमा फाइन्डिङ कसैलाई थाहा छ? द एकजना कसैलाई थाहा छ भने एकजनाले भन त. छैन? यहाँ हेर हैन, like what is there? There are, this is the CBD. Again, multiple small filling defects are there at the distal CBD. So these are the stones within the common bile duct. So again, it can cause severe biliary colic. So this is a case of choledocholithiasis. Now, what is there? Somebody has done, this is again the case in our hospital. Somebody has done the surgery for the gallbladder. Then again, the patient developed severe pain in the abdomen, abdominal distension. So we did the MRCP. So what we found, this was at the proximal CBD. Somebody has cut the proximal CBD. You can see the middle part of the CBD is there, and there is a leakage and large fluid was collection at the abdomen. So this is a biliary injury, which you can diagnose only by doing MRCP. ठिक छ, MRCP को बारेमा के कन्फ्युजन छ कसैलाई? MRCP को बारेमा कसैलाई के कन्फ्युजन छ?
छैन सर।
हैन है, तिमीहरूले के बुझ्नु पर्यो हैन, यो चीजहरु MRCP को इन्डिकेसन्स के हो, नर्मली के देखिँदो रहेछ र कुन कुन कन्डिसनमा MRCP गर्ने। अब यहाँ हेर ल, can someone of you tell me what is there? This is a CT scan. Anything is there in the CT scan? के छ? ल हाम्रो CR ले नै भन त, यो के छ? अहिलेसम्म त अरू सबै पढाइसकिसक्यो होला हैन। ल भन त के छ CT स्क्यानमा? दिस इज लाइक क्वाइट नर्मल। के confusion? Any confusion? There is a big mass, like on the upper lobe of the lung. So normally what you can do bronchoscopy and see, like what is the cause of the mass, whether, you can take the, like biopsy or not. But nowadays even in our CT scan, what we can do is we can do the biopsy, we can do the bronchoscopy without, non-invasive. It is called virtual bronchoscopy. By CT scan, you can see, you can, like send the, like cursor, or you can send the, like there is a app through which you can see this is the carina through the trachea. Now you can come to the bifurcation. Again, you can see this is the right upper lobe bronchus, which is occluded here by the mass. This is the bronchus intermedius and right lower lobe bronchus. Again, here you can see this is the left main bronchus, left upper lobe and lower lobe bronchus. So this is a case of virtual bronchoscopy. Okay. So now, similarly, we can do virtual colonoscopy. Sometimes the patient might not be, like they don't want to do colonoscopy. They are quite reluctant. And sometimes the, like colon might be quite difficult, or like maybe redundant colon, where it is quite difficult to, like send the scope. So on this case, together with CT scan, what we can do is we can do virtual colonoscopy. You can see these are the source images. These are the source images. And here, like you can plan accordingly, and you can see all the, you can see the hostra, everything. You can send the, like our track, like from the rectum up to the ileocecal junction. So now here you can see almost it is at the level of the descending colon. You can see there is a hyperdensity on the descending colon, and here on the virtual colonoscopy, you can see there is a polypoidal lesion within the colon. So you can do virtual colonoscopy. Again, here you can see this is the real colonoscopy, this is the virtual colonoscopy, and these are the CT scan images, which can also differentiate. There could be either, if there are any mass or any polyp or anything else, you can do virtual colonoscopy. ठीक छ, सबैले बुझेछ भर्चुअल कोलोनोस्कोपी?
Yes sir.
कुनै पनि पेशेन्टको अल्टर्ड बाउल हेबिट छ भने one of the indication of colonoscopy. तर अब पेशेन्ट, they are not like comfortable doing colonoscopy, they don't want to do intervention, invasive procedure. So we can do the CT scan and we can do the virtual endoscopy, virtual colonoscopy on the same setting. Which is not invasive. And the patient who are not that comfortable doing colonoscopy, they can have a screening colonoscopy, and after that again they can undergo colonoscopy if there is major indications. Okay. Now one of the like a recent advancement in the radiology is the intervention radiology. Right? Radiology ko main charm one of the beauty of the radiology is intervention radiology. Like anything, like whether you are doing biopsy, whether doing, like you can avoid some major procedures, like you can do, like you can put a pigtail, like catheter drain on the liver abscess, and you can drain it without doing surgery. Some major, like Schwartz abscess, you can do it, like through the guidance of ultrasound, you can see where is the abscess, you can put the drain over there. So instead of doing some big surgeries, which used to be practiced long back, nowadays you don't have to do this. Now, even through the vascular, percutaneous vascular, like channel also, you can treat a lot of, like major diseases. ल मलाई भन त एनीथिङ इज रङ इन द सिटी स्क्यान यो सिटी स्क्यानमा कुनै एबनर्मालिटी देखिन्छ कसैलाई थाहा छ This was a case of a, like one of the staff of our hospital, KUSMS staff. She had severe vomiting. She was supposed to go somewhere else, for some tour. Suddenly, she developed severe headache and vomiting. Then CT scan was done, which showed like very ill-defined hyperdensities within the cortical sulci and the basal cistern sylvian fissures. It was a case of subarachnoid hemorrhage. Now, what we did, immediately we give the contrast and we did CT angiogram. And CT angiogram revealed there was a aneurysm on the right middle cerebral artery with rupture. So, you can again see here, right middle cerebral artery, there was a aneurysm. Here, again, you can see on the BRT image, the same patient, there was aneurysm. Again, here you can see there is an aneurysm of the right middle cerebral artery. So now, what were the treatment previously? How this, this sort of things were used to be treated? The neurosurgeons used to put the clip. They used to do open the brain. They used to clip this part of the neck of the aneurysm and treat the patient. It was quite like a very, like invasive procedure. You have to open the brain, like give a big incision, like go to this vessel. You have to identify the aneurysm and you have to clip it. But now, like quite easily, like coronary angiogram stenting, what we can do, the intervention radiologists, you can see, they can put the, like catheter, and they can put the coil over there, like quite easy. Within 15 minutes, this surgery is over, this procedure is over. Patient is almost, like the hospital stay is almost reduced by more than, like 100%, almost, more than 50%. So within few days, the patient can go home. So, and the sensitive, even patient is quite comfortable. You don't need to touch the brain. You don't need to open the skull. So you can directly put a coil on the middle cerebral arterial aneurysm. It will be occluded. Everything will be all right. Again, same thing. Angiogram was done. Here you can see there is an aneurysm on the brain vessel. Now the coiling was done. After some times, the coil has completely occluded the aneurysm,